Hello, it's Dr. Scott McLean, and this is a failing implant that was referred to me, and so I'll show you. We had some bone loss evident on the x-ray right here. We also can see that there's a broken screw in this, and then there's a bit of a bend on the top of the implant right here. And so this is in a real problem. The patient wanted to save it. I just said, sorry, don't think we can, but we'll have a look. And so we look at the soft tissues that are growing over. And so our goal first is to have a look, and so to access and get in there. So we open up this area, and then I'm going to take a periodontal probe and just feel around down underneath, and it's not feeling too good. So I tell the chap that this has to come out because it's broken and because we have a bunch of other issues going on here. Not sure what the type of implant is. Haven't placed this type before myself, but it looks like a pretty good implant, but I don't think it was used properly, and I'll comment about that later. You'll notice that there's no pussism going in here. There's some inflammatory tissue, but no pus, which is good. And as we go in, we're going to take out some of this tissue and try to access this. So I'm going to use a serrated elevator from Hufridi. You can see the numbers here are listed on the side of it. And this serration will help us to grab the side of the threads as we're going to elevate this out, because I would have normally used a trephine to take this out, but the trephine is already down to the bottom 20% of the bone. So we really have to just get this out, and I can't get in to engage in the screws, so I'm just not going to not bother with that. So I take this serrated elevator and elevate against the side of the socket, and as I'm doing this, I can start this to be moved and elevate it out quite easily. The implant will feel quite firm, however it's very similar to a tooth at this point, and we elevate sideways here, and this will help to get this out. No, so I'm not really unscrewing it, I'm just getting it to dislodge from where the integration is still active on the bottom 20% of the implant. So taking it out, you can see that there's some issues with this implant. We look at it and it's got a lot of wear and tear. We can see the blue arrow shows the fracture area, and this is fractured and not repairable. We have a broken screw showing on the green arrow, and if we look at this other area, the yellow area, show where the bone level was on the implant. So very poor prognosis for this implant because we can't screw anything back on, and plus there's no bone. Now if we look at the screw itself, we can see it broke off way down inside of the implant, and it's also where the implant fractured. So this design was a long-term problem, but really it's not where I want to be when I'm trying to get a screw out, and so that's an issue. Now we'll try to do a cleanup on this area. So we'll clean the socket and rinse it with saline, get all the tissue out. Then we'll do a molt and kind of release the inside perosteum so that we can tuck the membrane down there eventually. And then I'm going to do this technique I've been playing with, which is to do a base suture. And so a base suture really is just doing a loop on the lingual so I can tug it one way or the other to get the collagen membrane down in that area a little bit easier. And so then the suture's there to start rather than trying to hold that little collagen and trying to put the suture in after. So I get that first one, and then I can tug it laterally across the tongue if I wanted to get inside there, because I've already released that area. Now we're going to use a Krios Xenoprotect collagen membrane, which is very resistant to tear. And we'll also use some mineralized cortical bone, about 1 cc, for this size of a lesion. And we'll start by taking the membrane and doing some cutting of it to make it fit. It is able to touch the two adjacent teeth when it's a collagen membrane, which is fine. We're going to cut it to fit so that we can keep the bone graft inside of the socket once we fill this up. So we have a nice socket that's not infected. So if it was infected, I wouldn't do this at this point. And certainly there's some stuff going on, but I feel confident this should be fine. So we're going to take some bone graft and then we'll mix it with some saline. And we'll take it to the mouth and we'll put it into the socket and start to fill that up. So using a bone spoon and malt, we'll use it just to fill up that tissue, dabbing it with gauze to take the moisture away and to make it so the bone graft gets flattened out. So we'll take this and making sure that we get a nice fill. But the goal of this is to we don't have to make a sausage here because we have a 4-wall defect, but we can just fill this up. And so if you let this keep going, we actually make it more difficult, but we're going to get probably a really nice product and have this so that we're able to put an implant in here about 5 months from now. So as we fill this up, we're going to get it up to the top and have the blood in that area so that we can generate some nice hemostasis and get the sutures in, close it back and forth to keep the membrane on top of this bone graft. So as we do this, we're going to just fill it, and it's a very simple technique. It's the most difficult thing is to make the decision about what you're going to do here. So as we go, we're going to start to put the collagen membrane in, and you can push on this thing. It's not going to be torn by the molt, and so we can tuck it inside. And as I do this, I'll tug on the lingual, so tug on the suture and lift it out. So watch me pull it right here. As I pull it, I can tuck the membrane into the lingual and make it into a little sandwich technique. So I'm not going into the socket itself, I'm going down between the perosteum and the bone, and then I'm going to start to then do the suture, bring the buccal flap back over and suture this tissue. Once I get it sutured a little bit, then I will pass through the membrane to tack it into place with the soft tissues rather than tacking it to the bone. And this will keep the bone graft into the socket, which really is going to firm up pretty quickly in the first number of days, and then the soft tissues can start to close over. So as I'm passing back and forth, I like to have a nice harpoon on this so that I'd actually like it to be a bit bigger than this one. And we'll pass it back and forth just so we can close the tissues but not have it too tight, and then keep that bone graft inside for that healing period. And then we'll come back and place another implant, and the guy's quite excited to do that. He wants to have his tooth back to get his quality of life. And so as we suture this up and have it ready to go, then he's going to be okay to have a new implant in the near future. And that's what the goal is to get it so it's going to keep it healthy and good for the long term. I always ask myself, why did this happen? It looks like a pretty good implant. Fractured, screw fractured. We had probably a loosened screw, but really look at this. The tissues itself are not very deep, so the vertical soft tissue here are breaking the rules of zero bone loss concepts. It's at 1.76 millimeters, and we need to have about 4 there. Here it's even less, and so you don't have enough tissue to seal this off, and this is important for long-term success. So if we look at the implant one more time, we can see it is thinned out. So the fracture that happened on this implant happened because probably there's some mobility, the implant's moving a little bit, and there's no support from the bone on the side of the implant, and therefore we have some problems with how this is going to be something that can be long-term. Now, it did last, I think the patient said it lasts 10 years, but at 10 years, patients don't want to pay again, so we want to try to make this last for the lifetime if possible. Now, we all have our own problems with implants, but when it's someone else's problem, it's always nice to help someone, but it's also nice that you didn't do it. Anyway, you can see here the broken screw. It becomes impossible to get that out if it's inside of the implant. So that's one of the designs you want to be careful of. If you're doing something when a screw breaks, you want to be able to get at it. So the top should come off, not at the base. I did place the patient on amoxicillin 500 milligrams, 1 tablet Q8H till gone. And this is Dr. Scott McLean, and this has been a presentation about how to remove an implant and do a ridge preservation.